record button for me? Perfect. There we go.
Tara, what room are we?
Pardon me?
What number room are we?
Mark, you are room 2.
Thanks.
So I am going to, just for the folks that are just logging in now, we were going to divide folks out into rooms, but since we're a bit of a smaller number today, we're just gonna stay together as a group. It'll just work, I think, a little easier, and we'll have more questions and be able to kind of talk. So we've set it up to record so everyone can reflect back on this, and we'll make sure that it gets posted. So welcome everyone to the GFAN's World Cafe, where we're going to hear from you about what you've been working on and what you want to share with GFAN members. We're going to start by introducing Roel from Farm Access. Do you want to go ahead?
Yes, shall I start sharing my screen?
Absolutely.
Okay, I'll do that. Let me see.
So I'm going to ask the presenters take 2 to 3 minutes to kind of do their presentation. Then we'll do 2, and then we'll open up the floor to questions, and then we'll move to the next group.
Yes, hold on. Let me see. Here it is. Okay, can you see this?
Yes, perfectly.
Okay, good. Shall I start?
Please go ahead.
Okay, a few minutes. My name is Roel Coutinho. I'm working for Farm Access. I have my whole life have been working in infectious diseases in the Netherlands and elsewhere. And what I'm going to present is a financing model to eradicate hepatitis C, and based on our experience in Cameroon. So as you can see here, this is a number of people who were cured from hepatitis C, and that's the way they dance to hear that message. Now, what is hepatitis C? Hepatitis C is a virus. It is transmitted through blood and unsterilized medical equipment. And the problem is that after infection, about 3/4 of the people remain chronic carriers for their life. And then you can find that if they are hepatitis C virus RNA positive. And about 20, 30 years, people do not notice that, but 1/3 of chronic carriers will develop serious sequelae like liver cirrhosis or primary liver cancer. There are about 71 million chronic hepatitis C carriers worldwide, and in Cameroon, which has 27 million inhabitants, due to mass treatment programs that were done in the past with unsterilized needles and syringes, before we knew that this is the way to transmit viruses, there are about 200,000 carriers, which is very high, and very few of them know that they are infected. And we have now an antiviral treatment, which is a great success. Within 3 months, people are cured, but that treatment is usually not available for people in low and middle income countries because it's very expensive. So what we did was we started a treatment program. First phase is completed. We used a combination therapy just to see whether we could achieve high cure rates as in high income countries. And indeed, we found a 96% cure rate among 161 carriers treated by a gastroenterologist in Yaoundé. And in phase 2, we are now, it has started. There we identify carriers among potential blood donors and refer from clinics, and they are treated with a combination of sofosbuvir and velpatasvir, which is a combination which is pan-genotypic. That means that you can use a simplified diagnostic algorithm. About 260 patients enrolled, cure rate 95%. And that's why we are using a performance-based financing structure, which basically means pay for success. How does it work? The direct costs are financed through an impact finance facility, basically an organization that takes the risk, and they are repaid by another organization through fixed outcome payments. And how does that work? 3 months after the 3 months treatment is completed, we check whether people have become RNA positive, negative, and if they are negative, then outcome payments are paid for each patient. And it's the validation and confirmation by an independent validator, and there is an independent facility agent that manages all fund flows. We also have a third project where people are enrolled in who are enrolled in an HIV treatment program, are tested for hepatitis C, and if they are positive, they are being treated. We have 5,000 patients tested. 3.25% of them RNA positive, and half of them started treatment. So, what is our objective? To roll out this treatment in Cameroon with the support of the Ministry of Health, based on the successful experience up till now. Identify the carriers through blood banks and clinics in additional regions, and also in HIV clinics. Use the simplified diagnostic algorithm, which means treatment with pangenotypic sofosbuvir and valproatovir from, in this case, that's a generic product, which is about 1% of the cost that we pay in high income countries. And we want to finance for pay for performance model with a fixed amount per cure patient. And again, I think what the strength of this is that basically you only pay for success. And that's very suitable for hepatitis C, because there is this treatment that you can give for 3 months with a very high cure rate. And one of course, we want to embed hepatitis C treatment in a screening program. I do have a backup slide where I give more details, but I think I'll leave it with here and ask so that I can answer questions.
Thank you very much. We're going to move to the next presentation, and then we will take questions for the two presentations. We'll next go to Maureen and Mark and Una.
All right, let me share. Can you stop sharing your?
Yes.
So that I can. Thank you very much.
Hold on.
Maureen and Juan, I'm going to go first quickly with the slides, and then go to you, because we're all doing this in one room.
Let me see. How do I stop this?
Hope that's okay.
Yes.
Yeah, this has been me at times. I understand.
See, you go to the share screen button, and you should have a stop. You should be able to just click stop share.
Yeah. But there is.
I'm gonna force it.
Yes, force it. It's easier.
Hold on, and then hold on.
Yes, very good.
Yeah, I like your screen. May I?
Hold on.
Okay. Good.
I've now lost all of my screens. This is like a comedy of errors going on here.
Should I try if I can?
No, you can go ahead now.
Okay, great. And full screen. All right. Can you see that?
No.
Not yet.
Hold on. My apologies.
No worries.
Can you see that?
Yes.
All right. Hi, I am Mark Lagon, and I am very happy to be here with my colleagues from Kenya and Vietnam. I'm with Friends of the Global Fight Against AIDS, Tuberculosis, and Malaria in the US. We're in a mutual learning and collaboration project with esteemed colleagues at Lean On Me in Kenya and SCDI in Vietnam. What is our project? We call it Health, Education, Advocacy, and Learning Series, or cleverly or not so cleverly, HEALS. We are working to convene 3 types of partners in Kenya, in Vietnam, and in the US. Health advocates, budget specialists and monitors, and those who monitor governance and human rights. And the purpose of our collaboration is to improve advocacy methods for domestic resource mobilization for health. There are lots of challenges that we all face, and I'd love your input about it. They include unclear budgets, corruption, lack of political will, and in particular, marginalized groups being neglected or discriminated against. We found in talking to colleagues around the world who are working on domestic resource mobilization that there are needs for better data, tools for costing out our asks as advocates, and the sense of timing and who exactly to go to. And so that's why we have this project. It's a partnership. It is strictly parallel between South and South and South and North. We hope to go beyond talking to actually advance capacity for advocacy. And so our pilot phase, not phrase, has the Lean on Me Foundation in Kenya, the Center for Supporting Community Development Initiatives, and GFAN Asia Pacific in Vietnam, and we, Friends of the Global Fight. And we hope to not only have long-term learning about fighting for countries to have domestic resource mobilization, but put this collaboration into use during replenishment. We've had a couple of meetings in Kenya and forming a plan for collective action. We're going to have an initial meeting in Vietnam in late March, some in person, some virtually. In March, or probably more likely May, we hope to have a joint learning convening in the US or virtually to learn across the 3 regions and countries, and then do advocacy together in the US to our Congress and executive branch for replenishment. And we'll at that point look at what toolkits, web pages, help desks we might want to create with best practices and success stories. And hopefully we'd like more African and Asian countries to join the project after a pilot phase, seeking additive funding. Maureen, do you want to speak to your hopes and visions?
Yeah, thank you very much, Mark, for the introduction, which I won't speak much because so much has been said in the introductory presentation by Mark, but I just want to say that as Lean on Me Foundation, to take up the urge to do advocacy for domestic resources was driven by the fact that constantly we see people missing their treatment and commodities, the increasing stockouts in Kenya for HIV and TB treatment. We have also seen the projects that have been piloted by donors are not being taken up by government after the end of the pilots. And so exciting things like point of care diagnostics and commodities for children were done very well by donors, but they are not being taken up. Funding for community health workers, as well as commodities for people living with HIV. So this really drove our appetite to start advocating for increased domestic resources for health to ensure that there's sustainability in the quality of health that people are receiving. Kenya is also unique in that it has devolved health systems, and therefore health decisions are made, health financing decisions are made at the county level. So this makes it very unequal. There's a lot of inequality from one county to another, in that some counties are giving a good percentage of their budget towards health, while others are almost giving something negligible. So this also puts us in a very unique situation to be able to design a strategy that works to advocate for equity between Kenyans in access to health. Thank you very much.
Thank you, Maureen. And I just want to quickly to say about our vision. My name is Oanh from SCDI's Vietnam. So really happy to be a part of this project from Asia. We have a couple of issues in Vietnam regarding to domestic resource mobilization for 3 diseases. One is that the government doesn't put much money, in particularly for TB and malaria. Vast majority of the funding is from donor. So for HIV now the treatment. The ARV treatment is covered by social health insurance, but the prevention is still heavily based on donor funding. And all the resources for community and civil society to work on community rights and gender and other issues, community system strengthening are entirely on donor. The government doesn't put any money on that. So we want to change that. Number one is that we want the government to increase domestic funding for the 3 diseases. We also hopeful that our government can start to consider and participate in the global fund replenishment. And the other thing is that we want the government to consider civil society and community as a partner and not just like an operative, like the one who delivers services for their convenience. So we, in this partnership, we was hoping that together with the domestic in-country advocacy and collaboration with international partner, and in this case, an organization from the US, from the Global Fight, we will be able to mobilize different stakeholders to participate in this and to make the change in the country. So it's learning and collaboration inside the country, outside the country, and hopefully that we will have the impact. Thank you.
Thank you so much, everyone. I'm sorry if I'm interrupting. I don't want to. If Mark, did you have anything more you wanted to add? You're on mute.
We need to turn over to our colleagues and with other projects.
Yes. So does anyone have any questions for those first 2 presentations before we turn it over to our next group?
I have a question.
Oh, excellent. Thank you, James. Go ahead.
I was really interested to learn about the partnership collaboration over the past year. I was interested to know, Mark, Marine, and others, if there's been any learnings and how this could be applied to other partners in the GFAN movement. So, for example, do you think there's an opportunity that would be helpful for like the UK, for example, to be involved in UK stakeholders to kind of do similar with this model, and thinking about how we in the UK could support some of the great DRM advocacy being done right now in Africa and Asia.
Maureen, do you have any thought or two about things learned so far or priorities? I can go.
We are really at the beginning of the project, but what we have learned from the sessions we have had is that there's a lot of ways of advocacy that we want to adopt, such as using very timely data and infographics, or rather simplified, shortened reports to reach to our decision makers, especially the members of parliament who don't have time to read 3 or 4 pages and who would just want to see visualized data and make decisions. So this is something that the Friends of the Fight US have done very, very well, and which we hope to adopt, and hoping that other people will adopt it too, because we know these politicians, sometimes they don't have time to go through a lot of detail, and a good quick infographic that will tell a lot of stories in 1 page is very, very important. So that is something that we are really looking forward to doing, and also to having regular meetings to monitor progress. Sometimes we do advocacy, but we don't monitor how it's going. And then we realize later at the end that maybe we had an impact or not. So this time around, we want to keep it really tight with close monitoring of efforts and what we are achieving and not achieving. Yeah.
Thank you.
Thanks so much.
Talk more, James. In the future.
Yeah, absolutely. I'm just looking at the time, and so if you don't mind keeping comments brief, we'll move on to the other presentations.
Yeah, I think for country like Vietnam, we really need the support from the international partner to put pressure on our government. In Vietnam, it's not about the technicality of the things. There are some, but I think it's more on the political. It is a political matter. Our government start to respond to HIV as a foreign relation, international relation matter. So I am thinking that the next step for domestic resort mobilization, it would be fantastic if we have a support from other international partners as well. So if we can do like a kind of collaboration with other partner from other country, the mobilization of different embassy, for example, then the chance of getting success would be higher. We are working very closely with the British embassy at the moment on the issue of LGBTIQ rights. It seems to move together with the EU and US and others. So yeah, I think it would be a that it may work in Vietnam. So be happy to further the conversation. I'm sure that Mark will be happy about that too.
Thanks, thanks everyone. And if anyone has further questions or questions for any of the presenters, feel free to pop them in the chat, and presenters can answer those questions in the chat while the other presentations are going. And I'm just looking at the time, and I want to make sure we get to everyone. So I'm going to move right away down to our next two. So I'm going to ask Catherine from Harm Reduction International and Leo from AIDS and Coalition Plus to be our next two. So Catherine, go ahead, please.
Thanks, Tara. Thanks everyone for this session. It's nice to be here and speaking to everybody about this work. So I wanted to talk about this at the last GFAN meeting, but didn't make it to Amsterdam last year. So I'm glad to have the opportunity to talk about it today. Part of the work that Harm Reduction International does is to map harm reduction investment around the world from donors and governments. And so I've just put this infographic, having not prepared a presentation, but I've just put an infographic on the slide about, our latest finding, which was published in a report earlier this year called Failure to Fund, where we found that, we've got a resource needs estimate of 2.7 billion from UNAIDS about what harm reduction funding is needed in low and middle income countries. And we found that we're kind of currently meeting 5% of that need, which is obviously a shocking kind of funding gap. The other thing we found was that the funding gap is getting wider. So the last time we looked at these figures was 2016, and there was 13% of funding being covered by donors and governments, and now we're looking at 5%. Part of the reason for that is that the resource need has got greater, and part of the reason it's got greater is because we haven't had the investment we've needed to date. So the kind of cost savings that could be made if you invest early on are not being made. And so there's more investment needed now to be able to meet the need. And the other part of our work that we do, well, actually, I'll just share one last infographic, which is an important one about where the money's going. So we also tried to look at the extent to which community-led organisations were receiving funding for harm reduction work. And it was quite difficult for donors to tell us whether community-led organisations were receiving their funding, because they didn't, they were kind of getting to grips with the definition, and they didn't really track it well within their expenditure and funding kind of systems. And governments, even worse, we couldn't tell whether governments were giving money to community-led organisations, and the data there is pretty poor anyway in terms of what money's going to harm reduction. So it was an area that we kind of flagged as something that needed to be looked at in the future, better reporting, better monitoring, and definitely more funding going to community-led organisations. The other part of the work that we do is to support our kind of partners in country and around the world to make the case for harm reduction investment. I'm just going to stop sharing the screen there. And so we've, over the years of kind of doing this work, we've developed some tools on how to track harm reduction investment at country level and at local level. And we've worked with partners in countries to use those tools to really have the evidence they need to be able to talk to governments and local policymakers about what funding is going to harm reduction and what the gap is, what's needed. And we've also kind of collated cost effectiveness evidence for harm reduction and sort of the best advocacy arguments for kind of funding for harm reduction. And then we also started to as a sector, talk about the potential for redirecting money away from drug law enforcement and, you know, punitive approaches to drugs in countries which we know that governments really heavily invest in. You know, a lot of the money within drug policy goes towards punitive investments, and at a global level, we're looking at about 750 times the amount going towards punitive approaches when compared to harm reduction. So we also developed a tool for civil society and community organisations to be able to look at what's being spent on drug law enforcement, to then really be able to tease out what savings could be made if people weren't imprisoned for low-level drug offences or possession of drugs, how much money could be saved, and then you could really talk about, you know, what you could do with that money differently to promote health and to support harm reduction. So pulling all of that kind of those tools and advocacy kind of strategies together in one place, we came up with a guide for budget advocacy, which is also quite technical area, and we worked with Leila Serebryakova, who had experience of doing similar work in Georgia and in the ECHA region, and she kind of really helped us to put a guide together that talked about what's possible if you're engaging in budget advocacy and how to engage in budget cycles, you know, the different parts of the budget cycle and where you can engage, who you might want to look at talking to, mapping out stakeholders. And so it's all kind of been compiled into this guide. And what we're hoping to do at the beginning of next year is to start working with partners in different countries on using the guide and you know, really kind of pushing some of this work forward. And so far we've got we're providing some technical support to the Ugandan Harm Reduction Network in early 2022, and we've also got some potential funding for work in other countries, but sort of yet to be determined, so I can't really talk about that yet, but hopefully we'll have some news there soon. And really, I just want to share amongst this group, because I know that there's a lot of emphasis on domestic resource mobilisation, and we heard from the group before, you know, the amazing work that you guys are doing, and just really want to be able to share and learn from each other's experiences, because, you know, it's a difficult area, and particularly for key population programming, it's got added complications and difficulties in kind of garnering political will for governments to invest. So just keen to share and to learn from others, really.
Thank you, Catherine. And just before we move it over to Leo, just remember, folks, to pop your questions into the chat. And what we'll do is we'll make sure that we'll make a chat script that we'll share with everyone with questions and answers, just in case we can't get to everyone on the call. And just to flag for Roel, there is a question for you in the chat. So please have a look. And if you're able to answer, that would be lovely. Over to you, Leo.
Thanks a lot. And congrats to the other presenters for such interesting presentations. It's my first World Cafe, so I'm not sure if you know, my project is really in the rules and the codes of the World Cafe, but you'll tell me, because I really want to present you that project we are leading right now. That is a press trip we are organizing in Côte d'Ivoire, and I'm gonna show you my screen if I can. Can you see the presentation right now? Yeah, perfect. So this is in the context of Global Fund advocacy, NVF funding. So that's really classic Global Fund advocacy. And we are really trying to do something that's linked to the communities. And so that's why we are organizing this trip with 3 organizations. So AID in France, so leading in HIV community fight. Coalition Plus for the international network of community-based organization, and Espace Confiance, so in English it must be a trust space, which is a community-based organization too in Côte d'Ivoire, that is trying to help marginalized and key population, and especially LGBT communities and drug users communities, and if I'm not mistaken, sex work also. So what we did is that we tried to find a way to shape this trip based on community promotion and community empowerment, and to present that that community impact and roles to French media or French-speaking media. And I'll show you next, because we really wanted to use 2022 and early 2022 before it gets too crowded in the political space for Global Fund, because even in France, it's really a particular year for the Global Fund and for global health in general. We are currently renewing our strategy, so our national strategy for global health. We are also taking, as you may know, the presidency of the European Union, and we have huge elections, so presidential and legislative, and it's going to be huge. It's going to be a tough time for global health, as we are starting to analyze it, and we are really afraid that it can be a time where our preoccupation and our priorities are threatened. So we're really trying to use that momentum in the beginning of the year to raise awareness among the general public and general opinion with main newspapers or TVs in France to talk about HIV, the reality of HIV, the necessity to fund and to have a successful replenishment for the 7th, and also to promote communities, because it's something that we are trying to do since I think 1984. We're trying to continue that. So you all know the importance of community. I'm not gonna learn that to you, but we saw in the last Global Fund report that the only item that was an improvement was thanks to the community workers, and so they are really central in COVID mitigation program, and the excellent study by the global Friends of the Global Fight was also a huge help to see that, and to see that HIV systems and networks also can be used, and community systems can be used to reinforce and to strengthen health systems and COVID-19 mitigation. So what we really tried, and what I really want to present you, is how we did that press trip, because it's something that's quite difficult to maintain a balance between the work of advocacy in France, so that's my work, and the work of community workers or management and project teams in Côte d'Ivoire, and the fact that we need to promote community, but without having a top-down or a north-south relationship that is biased. And that's really something that's quite complicated. And I wanted to present you how we worked on that, and how maybe your organizations did some press trips in the past or are currently working on that. So just sharing ideas and tools we are using. And so the objective, I already told you that the main objectives, it's classic press trips objectives, so community and media and strategic priorities. But that's really our main concern, and that we don't lose the reality of community-based approach by being in France and by organizing a big trip paid by United States fundings or French fundings, and to keep the reality of what is an important work and what is the efficiency of community-based approaches. So we are really using two main tools, because it's 3 organizations, so it's really wide to just bring people together and to have people from advocacy, people from communication, from budget management, for project management. And we are using a Google Doc, so that's really classic, and I think you all know that tool. But we are really trying to make that tool a simple tool that everyone can manage, and being a live tool that can present the state of work at any time. And even if you're not used, or if you're a new person on the project, you can really see easily how we are doing that. And that's why we have also a chronogram we are really using to just stay in time for everything. That we need also to listen to experts locally. So in West Africa, we also need to take into account several agendas. So the political team, also the journalist team, and to make this work without being a full-time project with 10 persons, that's really a challenge. And I'm quite new to my post, and I'm quite new in the advocacy too. It's only been 1.5 years, maybe. So that's something I'm really trying to improve by bringing something myself that I can do in France to make the project easier and smoother, and to make also the work of my colleagues easier, and for an important press trip like that to be something really simple, and really have the tools in hand directly. We are also we have been influenced by GFAN on something, on the regular phone calls. And that's something that really changed how we organize this press trip. We are trying to have weekly calls, really quick. Just, it may not be something new to announce to the team, but just to say, okay, everything is on track. We are just trying to manage this and this, but everything is okay. It can be 15 minutes. The one we had today in the morning was only 15 minutes. But it's really trying to keep the team focused and everyone on the same page. And one of the biggest challenge was the task allocation, as it is always the case in advocacy, and I think in NGOs and community organizations too, because that's something that's really important to keep in mind, that we need to have our fair share, but also need to keep a clear mind and not be too stressed about this project, because a project that is born under stress is not a good one, of course. And we're really trying to keep the balance between an important and deep work on that, but still by giving everyone spaces to adjust and to learn. And as we are community organizations, we're also trying to learn with that. We are not going to give everything to the journalists and being experts in global health or HIV. We are really trying to learn and to share experiences, and that's why also I chose to present you this project, because I think I can learn from any of your experiences. And if we are promoting some actions, some practices that are common in communities, such like experience sharing, and not being a hierarchy or having a top-down approach. It's something we're really trying to also implement in the project. So that's not easy, I have to say, especially that I'm quite young at this kind of project. But if you have any idea, if you had any experience by doing that, I will gladly listen to it. And I think that's the end of my presentation.
Thank you so much, Leo. Again, I'm looking at the time, and we don't, what I'm going to really encourage everyone is to pop your questions into the chat, and we'll make sure to publish those questions just so that we get through everyone's presentation and we hear from everyone. So apologies that we're not able to kind of do those questions live, but if at the end we do have time, I'm happy to open up the floor for people to ask questions. So presenters, please do look in the chat for questions and pop your answers in, and we'll make sure that they're they're all matched and shared. I'm going to now move to Ravati, then Crystal, then James. James, you're going to end this for us and hit that home run home. So we're just, Ravati, why don't you go ahead, please?
Thank you, everyone, and thank you for the invitation to GFAN, Tara, and Katie, and Quintin, and others for organizing this World Cafe. I'm Revati Chawla. I'm based out of UK in Brighton in the UK, and I have recently taken on the role of project lead for the civil society and communities platform of Act A. Now, I don't know the audience today. Unfortunately, it has the joys of Zoom have not permitted me to really understand who's in the room and what level of knowledge people have. So please forgive me if I'm repeating something you already know. But basically, ACT Accelerator, it is a platform that has brought together organizations across the world to lead on accessing COVID, accelerating the access of COVID technologies. So it is about accelerating access of COVID technologies. These three things are really important. It is not a new organization. It is a platform. And when we talk about COVID technologies, mostly we always hear in the news, vaccine, but vaccines is only one part of, the puzzle. The other part of the puzzle, of course, is the diagnostics and the therapeutics, and then the health system connector. As President Ramaphosa says, it is about converting the vaccine into vaccination. So how do you convert a vaccine into a vaccination? So, and a test into testing. So this is really, well, it is a political body, but my role really is what is more interesting, of course, which is why I'm here, is to facilitate and lead a group of community and civil society representatives on Act A. So they were elected through a process of nomination, and there are now 47 civil society and community representations across the 4 pillars of Act A. The Act A also has I would say the most political and visible body of Act A is called the Facilitation Council. And I could share a slide with you, but I don't want you to start reading stuff, so I'm not going to share that now. I'm just going to talk, and at the end I can share the slide and the resources with you. So the most visible platform of Act A is called the Facilitation Council. It is where the co-chairs of Act A sit. So it is governments of South Africa and the governments of Norway who are the co-chairs. And in this council, there is also civil society. So we have one civil society and one community representative on the Facilitation Council of Act A. They meet every, I would say, 2 months to discuss really like financing for Act A, how much money is needed, where is it going, accelerating progress. They have a couple of working groups under them, like one on tracking and accelerating progress, one on financing and resource mobilization. So it is an extremely complex and complicated world of Act A. And I'll share with you just now my screen, if I may. And let me know if you can see it. This is the screen. Can you see, Tara?
Yes, you're good.
Okay. So this is just to give you an idea that this is the structure of Act A. So as I was mentioning to you, the Facilitation Council, that is the most political, and visible body of Act A. But within Act A, there are different lead agencies. So because it's not a new structure, it's just a platform, it has brought together the so-called best existing practices and organizations to lead on different pillars. So you'll find the vaccines pillar is led by, Gavi and CEPI, and the World Health Organization. The diagnostics pillar is led by the Global Fund and FIND. And the health system connector, again, here's where a Global Fund, where Global Fund investment has been really instrumental, especially to this C19 regional mechanism, to supporting countries be ready to convert those vaccines into vaccination. So the whole health systems, the whole, how do you say, healthcare workers, community health systems, PPE, which is a big thing. Oxygen used to be in this, but now that has moved to therapeutics, but it used to be in the beginning, it used to be also part of the health system connector. So without that, really, you can't, no point sending vaccines which have, short expiry dates or small shelf life or low lead time, or vaccines that go without the proper training, or without the, just the vaccine and not the vials, or just, and not the syringes, not the other paraphernalia, that goes with it. Yeah, so I will pause the sharing. Then I would also.
We have only 10 minutes left in 2 more presentations. So if you have, like, if you're able to wrap, I'm sorry to interrupt. I just want to make sure everyone gets an opportunity to present. So if you have 1 or 2 more points you want to pull together, that would be fantastic.
Actually, you know what? I'll let people ask questions. I don't know their knowledge. And what I can share with you in the chat, if you don't mind, is our website. That's the Civil Societies and Communities, platform website. It is
Perfect.
still in progress, and a listserv that I please kindly encourage you all to sign up to if you're interested to know more around ACTA.
That would be excellent. That's perfect. Thank you so much. And I'm going to turn it over to Crystal now.
Thank you.
Yes, okay, thank you, Tara. I'm going to share my screen now. I hope everybody can see that.
Yes, we can see it. Go ahead.
Yes, great. So I'm going to be quick because there's not much time left. So my name is Crystal Birungi, and I work with Target Malaria at the Uganda Virus Research Institute. So Target Malaria is a not-for-profit research consortium made up of institutions from all over the world, and a really wide variety of specializations within our team, everything from molecular biologists to entomologists to regulatory experts. It's really, really a large team. And what we're trying to do is to develop and share novel genetic technology for vector control of Anopheles mosquitoes. So Anopheles mosquitoes spread malaria. Most of us, I'm sure, are aware of that. And in that way, then we shall contribute to reducing the burden of malaria in Africa. So our approach will be a complementary approach to the existing methods. It will be sustainable, long-term, and cost-effective. So our general aim is that when we reduce the mosquitoes that are transmitting malaria, then we're going to be reducing transmission and therefore the disease burden as well. So why did we choose genetic approaches? One, I want them to be compatible and helpful to other interventions. So we have a lot of interventions that really target malaria, but to be honest, our mainstay methods have been around for a while. The insecticide resistant spraying, and then also the insecticide impregnated nets and insecticides themselves. So those interventions have done something, but there's some gaps they have, like in use, there's some insecticide resistance and so on. So we want to be able to have a method that will work with them and bridge that gap in the areas that they are unable to reach. So also it has no cross resistance with other interventions. So just because you have insecticide resistance, for example, does not mean that a genetically modified mosquito wouldn't work. Oh yes, I did say something I wasn't quite right. That's what happens when you try to rush a presentation. It is IRS, insecticide residual spray, not resistance. So yes, it's sustainable and widely applicable. So it will work whether it's in urban areas or rural, whether we have high or low malaria prevalence, and also does not require strong health systems. Because it can be released in an area that's accessible, it means that the mosquitoes themselves would spread the control method even to areas you cannot reach. So it will work in unstable states as well. We want it to be cost effective because with genetic approaches, especially if you have a gene drive, then what happens is you only need a few releases to affect a large area. So it makes it easier to deliver and also means that the cost is reduced because you need fewer releases. So maybe the biggest question is, what is gene drive? I'm sure some people are already asking that. So once you modify, let's say a mosquito, you've identified the trait that you really want to introduce. Say you're affecting the birth rate, maybe like the egg hatching rate, maybe they don't lay as many eggs, or you skew the sex so that all the mosquitoes hatching are male, which don't bite, and therefore also affect the population size in time. Your gene only has a 50% chance of being passed down. That is what we call Mendelian inheritance, and that's the way things usually work. Now, with a gene drive, your modified genes are always inherited, and that is what we're trying to achieve. So the genes will always be passed down, which means that they will spread through the population a lot faster, and also that there's a much lower chance that you will lose your modification through things like genetic drift. Yes, so that is the brief summary that I have for you. Target Malaria is funded by the Bill and Melinda Gates Foundation, and also the Open Philanthropy Project Fund. I really hope I did not confuse everybody. I tried to go pretty fast. Yeah.
No, thank you very much, Crystal. That was very interesting. I am fascinated by mosquitoes. So I found it was very clear with the gene transfer. That is super interesting. Thank you so much. And now I'm going to turn it over to James. And there's been lots of questions popped into the chat, so have a look there. And I'm going to ask all the presenters to, if you've shared any slides, to please send them to me, and we'll make sure that they're shared elsewhere as well. We'll make sure that we find some other opportunities to share your work. So James, please go ahead.
Thanks, Tara. Hard act to follow after such great, interesting presentations this afternoon, but I'll try and be quick and keep it interesting. I've got no slides, but I've got an email I'll put in the chat, and I've got a link to the paper I'll be discussing over the next few minutes as well. So as you see in the chat, StopAIDS is looking to currently develop principles for aid-funded private sector engagement in global health. Why we're doing this? Because, as I'm sure all of you know, over the past couple of decades, there's been a substantial increase in the amount of overseas aid being channeled to the private sector to support the delivery of global development goals. So this could come from DFIs, such as the UK CDC group, and increasingly a positioning of the private sector as the only solution to a global health financing and delivery challenges, not necessarily the public sector. And of course, we've seen over recent years, global health agencies like the WHO and the Global Fund increasingly focusing on engaging private actors and broadening this scope as well. But this does come at a time where there's growing evidence to say that this increased engagement of the private sector in global health, it sometimes leads to actions that do more harm than good. So this could be undermining public health systems and sometimes negatively impacting the most marginalized and vulnerable populations, for example, with increasing out-of-pocket healthcare expenditures. So we've been in some thinking with some of our partners, what should the role of aid-funded private sector investments be, and what should donors do to mitigate against some of this potential harm. So we see in the paper some of the draft principles that we have currently. Our current thinking for the principles looks to say, for right now, aid-funded private sector engagement in global health should not, number one, undermine public healthcare provision. Number two, not be driven by commercial interests. Number three, must have a demonstrable development impact, be evidence-led, and adhere to the principles of equitable access to service. Number four, have strong transparency and accountability mechanisms in place to be in line with the principles of aid effectiveness too. And number five, to not promote private sector involvement in health in countries where there's not effective regulation of the private health sector. And lastly, to ensure that investments support and not undermine human rights, workers' rights, the rights of women and girls, and all marginalized communities as well. So as I mentioned, we've been having some conversations with some of our partners on this and thinking about how we could use potentially these principles to advance our advocacy. I'm not sure how much conversation we can have in the last minute, but I was really keen to get everyone's ideas and consultation on this too. So please do reach out to me if you wanted to feedback on the Google Doc. Really keen to kind of have one-to-one meetings with you as well, particularly on what you think about the principles. Are they applicable? Do you agree? Do you disagree? Anything key missing? So really keen to kind of carry on that dialogue, and I'm sure Tara and GFAN or myself would share around the Google Doc afterwards as well, too. But thank you very much.
Thank you, James, and I'm really sorry that you got you kind of got crunched down there at the end, but we'll make sure to share all of these presentations, and Contan and I will have a discussion about how we can share each of the stories, or each of these presentations individually with everyone in the new year. So thank you all. Please do, if you have any additional questions, I'll leave the call open, and we'll stop recording, but I'll leave the call open and you can pop questions in, and I'll make sure presenters get those questions, and we can have, and I can make sure that they're all answered. So I'll follow up if your question hasn't been answered. I'll make sure it does get an answer. So I want to thank everyone for joining today. This is our last GFAN call, where I can see the numbers dropping quickly. So I know everyone has to run to other calls. So I want to thank everyone for joining today, and appreciate it, and have a great rest of 2021. And let's hope that 2022 brings us all some in-person something. And I get to see many of your smiling faces in person again. So thank you all, and I wish you all well. And I'm out of words. I need another cup of coffee, apparently. So thank you, and have a great and lovely rest of your day.
Thanks, Tara. Thanks, everyone.
Thank you, Tara.
Thanks,
everyone. Thanks, everybody. James, I
Thank
put some
you.
thoughts in the chat. Oh, he disappeared already.